I want to move on to the second portion of our talk this morning that addresses substance use disorders in the older adult. We're in an interesting time in psychiatry because we have in psychiatry our, I don't want to say Bible, but our roadmap, our road atlas, is the Diagnostic and Statistical Manual. And for my entire training and career, if I can call it a career, we've used the Diagnostic and Statistical Manual, fourth version, or the DSM-4, to really define what these psychiatric conditions are. Now, the American Psychiatric Association has just come out with the DSM-5, the fifth iteration of the Diagnostic and Statistical Manual. And so, is it terrible? Okay. It's done some interesting things with substance use disorders, hasn't it? What it's done, and I'm going to kind of rely on some of our W.P. Farley folks to flesh it out for me, but it's sort of combined substance dependence and substance abuse as a concept and sort of made a grab bag, which some people find good and some people find bad, but it really has made it difficult to put together a presentation about substance use disorders right now because the definitions are changing. And the other thing I noticed is that we're going to have to apply the existing literature to the new definition. So I'm an MPH, I'm an epidemiologist. So for me, this is kind of breaking my brain because you really, to do research, and the Diagnostic and Statistical Manual that we use in psychiatry was developed as a research instrument. We use it clinically, but it was originally developed so that researchers could define their terms and be uniform in the entities that they're talking about. And now that they're changing definitions or modifying things, we're not quite talking about the same things, but all the literature that we've got, that's what we've got. So we have to kind of take everything with a grain of salt in a way now, or get really creative in the way we describe things. And so you'll see maybe some awkward language sometimes in this presentation. It's going to take some getting used to for me too. But I'm going to go ahead and get started. Just to frame the conversation, we find that older adults with substance use disorders are a growing population. And they're very vulnerable to the effects of the substance itself, but also to other related problems, social or functional problems that revolve around the substance use. The assessment and treatment of older adults raises unique challenges, partly because of those defining terms, and we'll talk about that at some length. Substance problems in older adults will often go unrecognized for this reason, and if they are recognized, they'll often go undertreated or mistreated. And the standard diagnostic criteria for abuse and dependence, or now the big grab bag of substance use disorder, are difficult to apply to older adults. And that's one of the things that contributes to these substance use disorders kind of sliding under the radar sometimes. So this is a terribly messy slide. This is under the DSM-4, the substance dependence criteria. So the DSM-5, there's substance abuse, which is a separate, or was a separate entity with separate criteria, and there's substance dependence, which has a physiologic component that, among other things. Now the DSM-5 kind of stacks them all together. I didn't want to get into all that. I want to focus specifically on the substance dependence definition to highlight some of the diagnostic challenges that older adults present when assessing and treating substance use disorders. Briefly, substance dependence, so whether it's alcohol or cocaine or benzodiazepines or whatever, the substance dependence is defined as a maladaptive pattern of substance use that, again, significantly impairs function or causes distress. And you have to have, again, this is a criteria-driven specialty, so it's 3 from column A and 2 from column B. So you have to have, 3 or more of the following. Tolerance, so you need more and more of the substance, or you get a diminished effect from the same amount of substance. So tolerance, withdrawal, okay, physiologic symptoms when the substance is stopped, a need for taking the substance in larger amounts to achieve the desired effect, or being taken for longer than intended. So unsuccessful efforts to cut down, increased time spent in activities surrounding the use of the substance, or giving up activities that as a result of the substance use, and continued substance use despite knowledge of having the persistent problem. So that's literally the textbook definition, the criteria for a substance dependence, part of a substance use disorder. And that's applied to the general adult population. But in older adults, you have some factors that make these criteria difficult to apply. For example, again, with respect to tolerance, older adults have a higher sensitivity to these substances, even at lower levels of intake of the substance, because of those changes in body fat distribution, liver function, kidney function, enzyme availability and capacity. What it can be easily identified as tolerance in a younger adult is not so easy to identify in an older adult because of their physiologic response to medications. Withdrawal symptoms, older adults who develop substance abuse in late life might not immediately show signs of physiologic dependence. So their substance use might not have a significant withdrawal component. And again, you have to meet a certain threshold of criteria for the diagnosis to be valid. Is taking a substance in larger amount or over a larger period of time? Well, cognitive impairment can interfere with self-monitoring. Again, psychiatry is subjective. We don't have a lot of objective measures, so we rely on what the subject tells us, on what the patient tells us. And older adults with cognitive impairment might not be able to relate accurately what their duration or what their amount of substance use is. So cognitive impairment can interfere with self-monitoring, and substance use can in itself exacerbate cognitive impairment. So you get this downward spiral of the quality of data that you're getting regarding this domain. In substance dependence, you talk about a persistent desire or unsuccessful efforts to cut down. Well, older adults might not try to cut down, either because they've been, it's a lifelong addiction, or they don't understand the harmful effects, so they don't have that motivation to try and cut down. It doesn't sort of occur to them to try to cut down. Time spent in activities necessary to obtain the substance, use the substance, or recover from its effects. Well, certain substances, like prescription medications, which I will talk about, might be more available. Access might be enhanced simply because the doctor is writing you a prescription and giving you your supply. So you don't have to spend so much time. You won't meet that criterion. And then in classic substance dependence, you can have important social, occupational, or recreational activities given up or reduced because of substance use. Well, older adults might have fewer activities anyway. For any number of reasons. Older adults have more free time, or again, as their roles are reduced, as they're not working anymore or not running a household anymore, well, they have more time on their hands. Studies have shown that increases in free time and reduction in role obligations do impact problem drinking in women especially. And age-related losses, retirement, bereavement, decline in physical ability, contribute to the development of older drinking patterns in older men and women. Again, this is one activity that they can still pursue. And continued substance use despite knowledge of having a problem, well, older adults might not know or understand, again, maybe as a feature of cognitive impairment, that they have a problem, even after the physician has sort of counseled them. So there are difficulties in applying diagnostic criteria to substance use disorders in older adults. Now, I want to speak about the different types of substances that we see in substance use disorders in older adults, and I'm going to start with illicit drug use. Although rare, it's more common than we previously thought. The initial estimates were low, but now, again, as the cohort ages, as the baby boom cohort ages, we're actually getting more frequency of illicit substance use. There's a higher rate of illicit substance use among older veterans. So they found that there was up to 38% illicit substance use, and I was like, 38% illicit substance use in older veterans, and then I read to the end of the sentence, in an addiction treatment program through the Veterans Administration. I was like, oh. So you kind of have to carefully frame the discussion, but the literature does show that there's a higher rate of illicit substance abuse among older veterans. And just to give you an example, one of the national health studies from the U.S. Health and Human Services Agency showed that in a 4-year interval from 2002 to 2006, illicit drug use in those adults 55 to 59 increased from 1.9 to 2.4%. Now, that was the only age group with an increase, a notable increase in illicit substance abuse in that interval. The baby boomers were the only, the baby boomers were the only age cohort that showed a significant substance increase. In other words, it wasn't the same users in 2002 are there in 2006 still using. It's, no, there are even more users in 2006 than there were in 2002 in that baby boom generation. And now the baby boomers have begun to enter Social Security age and retirement age. So we're going to see this trend shift forward through the demographic. I'm going to move on to alcohol use disorders. Prevalence estimates in terms of the number of people with either a lifetime or current alcohol use disorder, it varies. And again, it varies depending on definitions or criteria. Because some people talk about problem drinking, some people talk about at-risk drinking, and then there's alcohol dependence and there's alcohol abuse. Problem drinking, the prevalence of problem drinking among elders ranges from 1 to 16%. And Hazelden puts out a study that estimates the prevalence at about 17%. 14% of men and 3% of women over 65 engage in binge drinking behaviors. Assessment of alcohol abuse in elders starts with a high index of suspicion by a clinician. And speaking of not alcohol, but cocaine, when I was a medical student, there's a cardiologist at Tulane, phenomenal physician, and she was in the ER and she was interviewing a lady, a grandmother, I think she was 68 or 70, who was having chest pain routinely about 10:30 at night. And she could not figure out, she did a complete history and physical and couldn't figure it out. A 4th-year medical student was doing a history and physical just because they got to learn how to do a history and physical, and they said, well, do you drink alcohol? Nope. I go to, I'm a churchgoer. I never drink. I don't smoke. Nothing. He said, okay, do you use cocaine? Oh, yeah. My grandson is a crack dealer, and he gives me crack as a present, and I don't want to hurt his feelings. So every night when the 10 o'clock news comes on, I have some crack. It's like, and you get chest pain around 10:30. It's like, yeah. So, and Dr. Ledoux, I just outed her. Dr. Ledoux, Elma Ledoux, she's a great cardiologist at Tulane, but she told us this story to kind of tell us, don't be guilty of ageism. Don't just assume that because you're dealing with a grandma that they're not using illicit substances. And it's the same with alcohol. Clinicians tend to shy away from questions about sexuality or substance abuse with somebody who looks like your grandma. That's ageism, and you really have to ask. And since I heard that story, I always ask, do you smoke? Do you drink? What about other drugs? Marijuana, heroin, cocaine? And I ask 93-year-olds, I ask 97-year-olds. Of course, they laugh usually, but it doesn't stop me from asking. People tend to minimize their use to providers, and that's pretty much across the lifespan that, alcohol intake is minimized when you're talking to a physician or a nurse. So it's important to obtain collateral history from relatives or people, in the elder's life. In terms of laboratory findings, you can get increased liver function tests. You can get increased mean corpuscular volume, which you see on a CBC, and it might be more sensitive in elders. It might pick up more cases than it does in younger adults because, again, physiologically, they're more susceptible to the effects of the alcohol. And ask about withdrawal symptoms, but the caveat is that a lot of the withdrawal symptoms that you see in alcohol withdrawal can overlap with other physiologic conditions in elderly. Tremulousness, for example, blood pressure fluctuations. So you have to screen very carefully. The Substance Abuse and Mental Health Services Administration guidelines recommend that all adults 60 and over be screened at least once a year and rescreened with any major life event like retirement, loss of a partner or spouse, any potential stressor, okay? At minimum once a year and with every potential life stressor or potential life adjustment. This is put out by the World Health Organization. It's the audit alcohol screen. This is one of the screening instruments that they recommend as a screening tool for substance use in all generations, and they do it has been shown to identify cases of alcohol use, disordered alcohol use in older adults. It's pretty complex as a clinician. This isn't my go-to. This is more my speed as a clinician. This is the Short Michigan Alcoholism Screening Test geriatric version. I, as a clinician, tend to be biased in favor of screening assessments that are geriatric specific for the reasons that we are talking about today. And the thing that I really like about this is it's short. It's only a few questions. Like when talking with others, do you ever underestimate how much you drink? After a few drinks, have you sometimes not eaten or been able to skip a meal? Does having a few drinks help decrease your tremors? Does alcohol make it hard for you to remember parts of the day? Do you take a drink to calm your nerves or take your mind off problems? Have you ever increased your drinking after a loss? Has a doctor or nurse ever said they were worried about you? Have you ever made rules to manage your drinking? When you feel lonely, does having a drink help? So, and you score it in 2 or plus more points indicate that you might have an alcohol problem. So it's a good screening instrument for a geriatric population. The CAGE questionnaire is very popular, but the utility of it is pretty controversial. As it's important to ask is the take-home message. In terms of the comorbidity of alcohol use and depression in older adults, 20% of older adults with depression have a co-occurring alcohol use disorder. So if you talk about a Venn diagram or the interface of alcohol use, disordered alcohol use and depression, it's significant. Among adults 65 and older, more than 13% with lifetime major depression at any time of their life also met criteria for lifetime alcohol use disorder. Recent studies have shown more than a 10-fold increase in suicide attempts among alcohol abusers in a Scandinavian country. Okay. So in this population, there's a 10-fold increase in suicide attempts among alcohol abusers. And so in the substance abusing elders, it's always important to ask about suicidality, regardless of what other depressive symptoms they might have. The alcohol abuse by itself is a risk factor for suicide. In terms of the effects of alcohol in older adults, men and women 60 and older who drink more than 7 drinks per week have greater impairments in their instrumental activities of daily living. So driving, managing finances, using a telephone, shopping, housekeeping. Okay. And more than 3 drinks per occasion is also associated with impairment in these activities among older adults. The minimum sort of acceptable limit of alcohol use is lower in older adults. There are many alcohol-related illnesses in older adults. Older adults who have alcohol use disorders are more susceptible to have disordered sleep, cognitive dysfunction. Again, alcohol in itself worsens cognitive function or causes confusion. Cardiovascular disease, they're at increased risk for high blood pressure, cardiomyopathy, or cardiac conduction abnormalities, abnormal heart rhythms. Their risk for certain types of cancer are elevated. Esophageal cancer, alcohol use is the classic risk factor for esophageal cancer. And they're at risk for neurologic dysfunction, peripheral neuropathy, vestibular dysfunction, so affecting balance. Orthostasis. Orthostasis is fluctuations in blood pressure and heart rate depending on what your posture is, whether you're lying down, sitting, or standing up. If you've ever stood up abruptly and gotten dizzy, you're orthostatic. And so alcohol affects the ability of your heart and your body to maintain a stable blood pressure and heart rate. Falls are a dreaded syndrome in the elderly, and alcohol contributes to risk of falls. Hip fracture has a 50% mortality. So gerontologists live in fear of falls, and we try everything we can to prevent falls, and so alcohol can actually increase significantly a risk of falls. In terms of the treatment of alcohol abuse in elders, it begins with prevention, and the literature has shown that a brief alcohol counseling session, and they actually will publish sort of scripts for clinicians to use, in high-risk individuals and individuals whose drinking is more than in the acceptable limit but haven't necessarily had associated problems that have manifested themselves yet, that has been shown to be effective in curbing problem drinking. And in terms of patients with an alcohol use disorder, both 12-step programs and CBT-based styled programs have been demonstrated to be effective. In terms of the medications that we use to help reduce the risk of relapse in alcohol abusing individuals, there's really not that much data in older adults. This is true for most medications, by the way, as the literature and the research is usually on individuals under age 65 or under age 70. And so you're always kind of having to extrapolate to the older population. There's also the question of how to treat cognitively impaired older adults. A CBT-styled program is not going to work for a cognitively impaired elder. So you really have to find out, alcohol, again, contributes to your risk of vascular dementia. So how to modulate that alcohol use in a demented elder is a big challenge. There's also the term in gerontology of substance misuse. It's not abuse, it's misuse. So it's inappropriate use that might even be unintentional. And when we talk about substance misuse, we're talking mainly about prescription drugs and over-the-counter medications. So the risk of misusing pharmaceuticals does increase with age, and that makes sense because the risk of being on a pharmaceutical increases with age. Commonly misused pharmaceuticals include, yes, certainly sedatives and hypnotics, so anti-anxiety medicines and sleep aids, but also narcotic and non-narcotic pain meds, diet aids, and decongestants. Diet aids tend to be stimulants, as do decongestants, by the way. In terms of prescription medications, there's not much literature on the prevalence, the frequency of prescription misuse in older adults, but the available literature indicates that 11% of older women misuse prescription drugs, and that it's projected that by 2020, 2.7 million adults will be using prescription drugs for non-medical purposes. So this is, again, going to be a growing problem. And women, especially for older women, they're at higher risk for misuse of prescription drugs. What are the correlates of prescription and over-the-counter misuse? What can be associated with this phenomenon? Declining physical health, again, declining physical health and therefore access to these medicines. Age-related physiologic changes. Practices of the prescribing healthcare provider. And gender. Let's talk about the provider's role in raising the risk of prescription and over-the-counter misuse, medication misuse. Inappropriate prescribing practices, so not prescribing the right medicine or prescribing a medicine for one condition that has problematic side effects or that's not indicated for that condition. Insufficient monitoring of drug reactions or response of medications or side effects, and insufficient monitoring of patient adherence. Are they taking too many of their medicines? Are we keeping track of that? Are they taking it too frequently? Do they have frequent refills? Do they run out too soon? And continuation of medications from one care setting to another without clear justification for use. So this can contribute to substance misuse, among other problems. And this is why in the hospital these days, the Joint Commission requires that on admission, there's a medication reconciliation that's done so that you look at the outpatient medicines and say, okay, can we stop this? Can we change this? And you do that at discharge as well. What are the gender correlates with prescription and over-the-counter drug misuse? Older women are less likely than older men to use and abuse alcohol. However, older women are more likely than older men to use and misuse psychoactive medications, particularly if those older women are divorced or widowed, have lower socioeconomic status, SES, or have a psychiatric illness like depression or anxiety. So that further increases their risk of substance misuse. Benzodiazepines are a commonly misused prescription medication in older adults. It's one of the most commonly prescribed medications in the US. And the use of benzodiazepines, alarmingly for me, increases with age and tends to be chronic later in life. As a geriatric psychiatrist, I consider it one of my principal goals to avoid benzodiazepines in older patients because they affect balance and gait, they contribute to the risk of falls, and they contribute to confusion and cognitive impairment in older adults. And while they can be used effectively to treat anxiety and agitation in younger patients, they are paradoxically disinhibiting sometimes in older adults and can contribute to delirium and agitation. However, 53% of nursing home residents are on a benzodiazepine, or 2 benzodiazepines I've seen, or 3. And of those 53%, 59% are prescribed for sleep disturbance. And 17% are prescribed for anxiety. Of that 17%, more than 50% of those who are getting a benzodiazepine for anxiety aren't getting an antidepressant for anxiety, which is really first line. And for me, for anybody of any age, if I'm giving them a benzodiazepine for anxiety, I better be giving them an antidepressant because that's treating the underlying cause and the underlying phenomenon and not just treating the symptoms. 25% of hospitalizations from adverse drug use in older patients are from benzodiazepines and opiate drugs, which is a segue to the opiates. 12% of older adults use narcotic medications, opiates. 33% of inpatient admissions for opiate detox or treatment are for older adults, 65 and older. 80% of institutionalized older adults have chronic pain. Opiates, by the way, are not classically indicated for chronic pain, and yet they're very commonly prescribed for chronic pain. And 80% of older adults have a chronic pain substance for which they are often prescribed opiates, which would be an inappropriate use of opiates most of the time. And up to 10% of older women who are prescribed opiates misuse them. So what are the guidelines? What can I as a physician do to prevent prescription and over-the-counter medication misuse? Well, and when I was preparing this slide, bullet 1, duh, bullet 2, duh, bullet 3. So use caution when prescribing or recommending treatment. Well, I hope I would do that for any medication for any patient, is to really try to have a reasonable rationale for exposing a patient to the risk of any medication. And take both the risks and benefits into account. Clearly communicate guidelines for appropriate use to patients, and I pulled this from the literature, communicate to patients, and I added, and communicate it to the caregivers as well. Because you've probably been to the doctor and gotten instructions and left the doctor and not remembered what the doctor told you. Imagine if you have even mild cognitive impairment, you're going to have difficulty remembering what it was the doctor told you. So it's good for an older adult to have a little bit of collateral response. The printed instructions, now that we have the electronic medical record, the printed instructions are fantastic. The second step, though, is making sure that it gets to daughter, son, spouse, caregiver. And discontinue medicines that do not prove effective. Well, that sounds like a no-brainer, doesn't it? But I can tell you, in the hurly-burly of hospitalization, when people are flying in the door and flying out the door, very often we will fail to discontinue medications that should be discontinued, and they can have all sorts of side effects, including cognitive effects. So it's really important. That's why I always recommend that after a hospitalization, you see your primary care provider. National guidelines recommend that after a psychiatric hospitalization, patients see a psychiatrist within 7 to 10 days. And I say further that regardless of what you're hospitalized for, whether it's for psychiatry or surgery or whatever it's for, you also follow up with your primary care provider within 2 weeks because medications get changed in the hospital and you really need follow-up. Okay. So I've come very quickly to the end of my presentation. I thought I had more than that. But this allows me time, and this actually helps us because we're finishing close to on time now. There were about 30 or 40 slides on that presentation, and I thought it was going to take me an hour and a half to do it. This is the first time I've done that particular portion of the presentation, by the way. So I think I covered the main concept of what I wanted to cover in terms of the phenomenon of substance abuse in older adults. And now I can open it up to your questions or comments. Go ahead.
Okay, back in the 70s and 80s, I was treating older adults. We knew back then that that was a problem. The biggest part and problem we had in treating them was that the family members would say, oh, well, you know, they're old, they don't have much pleasure in life, let them drink.
Mm-hmm. Yes. Right.
And I think we're still having that problem.
We are. I also, by the way, I see the same thing with firearms. You know, because it's like, what do you mean Grandpa can't go hunting? You know, and I get it, but you do have to advocate for safety. One of the contributing factors that they have found in terms of alcohol use disorders in the elderly, one correlate is the attitude of elders' friends towards their alcohol use. So that speaks to what you're saying as well with the family, is they minimize the potential effects. And you know, they don't have much pleasure, so let them use alcohol. You know, I wouldn't want to talk to the family of a serial rapist. You know, it's like, oh, well, he's old, so let him keep doing it. Yeah, it doesn't make a lot of sense, but it is commonly seen. And the research shows that the attitude of the support system does affect the alcohol use. Yeah, that's absolutely true.
In '94, a psychiatrist and I were working for a day program, a partial hospital. Mm-hmm. We had a 90-year-old patient that came in for depression, and she had been on lithium and Valium for over 40 years. Mm-hmm. Took us over 10 months to detox her.
Right. So Valium is a benzodiazepine, and it's important to remember the withdrawal syndromes for alcohol and benzodiazepines like Valium are potentially fatal. And older adults might find themselves suddenly without their medications, and they could be in real trouble. And Valium has a very long half-life. So the withdrawal management for an older adult whose metabolism is slowed for a drug with a very long half-life is very complex. And then lithium, while it's a phenomenal mood stabilizer, it is toxic to kidneys and thyroid. So 40 years is a long time to be on lithium, it's a long time to be on Valium. Orthopedists, I find, are very fond of Valium because among the benzodiazepines, Valium is also a good muscle relaxant. But it's a problem for an older adult because of that long half-life and because of the cognitive effects. So I've had consults on the orthopedics floor when I was in Chicago of patients on Valium, and I said, oh, I'd really rather not have them on that. The other thing that I see in the elderly a lot of times is what I call triple diagnosis, the comorbidity of a substance use disorder, a psychiatric illness like anxiety or depression, and chronic pain. And I had a woman who came to me for years. She had been on clonazepam and she had been on Norco because she had chronic pain, she had anxiety, she had severe anxiety and depression. And she was on a narcotic and a benzodiazepine chronically. And one of the things that she told me was, she said the clonazepam, the benzodiazepine, that doesn't help my anxiety at all. The Norco helps my anxiety. So these are, chronic pain, mood disorder, anxiety, depression, substance use, they can coexist and they can modulate one another. In other words, they can amplify or exacerbate one another. And it becomes a cycle. You really have to treat all of them to be able to treat one of them successfully. And that's very common in the elderly, a co-occurrence of substance use disorder. When I say it's very common in the elderly, it's very common in what I've been exposed to and what's come into my office. Substance use disorder, mood disorder, chronic pain. And you really have to be very diligent about the management of all of those. And so as a psychiatrist, what do? I pick up the phone and I talk to their internist about the chronic pain. Can we get them on a topical gel, a topical analgesic, Voltaren gel? Voltaren should send me a Christmas card because I put a lot of people on it. Because it's topical, it's not absorbed systemically, so it doesn't have a lot of systemic side effects. It's effective for pain and it can get people off a narcotic, which can be Voltaren gel, diclofenac. It's very expensive. It's an NSAID. We actually give it systemically, but it comes in a topical preparation. It doesn't work for everybody, but for people that it works a charm. And whereas the NSAIDs like ibuprofen can really do a number on your stomach or your kidneys, topical diclofenac, that's what Voltaren is, diclofenac, it's not systemically absorbed, so it doesn't have those same side effects. And it's really important in treating people's pain because are you going to feel well emotionally if you don't feel well physically? Are you going to use substances more if you have physical pain? So addressing those issues is a real challenge. Any other questions or comments either about substance abuse, substance use disorders, or gerontology in general?
Real quick without that, one of the biggest substances abused over the counter are medications or things like fiber to have to deal with constipation. Seniors seem to think they have to have a bowel movement every day, but their food intake is going down.
Mm-hmm.
So they go with this whole idea of every day, and so therefore they're constantly using
Right.
kinds of I forget the name of them. I'm getting old, I even forget words.
So yeah, they get obsessed with bowel function. And they're, in older adults, your bowels don't function as they used to, and it is uncomfortable. You're also probably not hydrating as much as you need to be, and you have insensible water losses, and that contributes to constipation. So yeah, laxative abuse is seen, and they have to sit down with their internist, and their internist has to give them education and say, look, every other day is what we're shooting for. You start with fiber, you start with water, and then you can augment from there. And monitoring of their bowel movements, but also their laxative use or their fiber use is important as well. The other thing is we are seeing an increase in eating disorders in older patients, believe it or not. There's one of the textbooks that I read says narcissists do not age well. People who are very focused on their physical appearance have difficulty with the aging process. So we are seeing an increase in eating disorders, and so you can see laxative abuse with that. But we see a lot. In this region, I've seen more decongestant misuse than I did in Chicago. In Chicago, it was a lot of narcotics and a lot of benzodiazepines. But here, I've started to see some decongestant use, which I hadn't seen. But the literature shows decongestants and diet aids are commonly misused in older adults. Anything else? All right. Thank you very much for taking the time to come this morning. I appreciate it.